Welcome everyone who is here to the ERN GUARD-Heart webinar number 14. And today we have presentations from the congenital heart disease domain. The title is 4D Flow CMR in congenital heart disease. And a special welcome to our speakers, Dr. Francesca Raimondi from Florence and Dr. Arno Roest from Leiden in the Netherlands. And a special welcome also for Professor Didecum from Washington, who hopefully will join us soon as well. Well, I think we can start. So I will give the floor to Francesca.
So thank you very much for this invitation. I'm really happy to speak about this specific topic that I care a lot. About 4D flow, MRI, CMR, and congenital heart disease. Actually, I will try to give you an overview of this technique. Try to make it simple a little bit for all people that maybe are not specifically inside this technologically speaking, and try to give you the basis to understand actually what's following, and especially what Arno will speak about a specific pathology studied with this technique. So 4D flow MRI, it's really simple to describe. It's a sequence, really simple to explain, because it's just the capacity of a sequence of MRI to encode the velocities in a 3D volume in the 3 direction in the space. So actually you acquire with this sequence a volume, and in this volume, all the points that you are acquiring have 3 vectors in the 3 spatial directions. It's a really comprehensive sequence. It's not a new sequence, because actually the first attempt to have this kind of acquisition was made more than 20 years ago now, when some physicians actually, they understood how to acquire the velocity fields in the 3D volume. And in the first consensus statement in 2015, we already established actually the 3 major parameters that you can study with this sequence. And this is just an example of what you can study in vessels about velocity. So you have vectors, because for all points, you can have your 3 vectors in the space. You have velocities for, of course, all the points, and then you can follow your point, and so your velocity in the time, so the streamline, because it's a 4D, because it's a 3D acquisition in real time, so in the time. In this consensus, actually, there were the parameters, the classical parameters, and then some advanced analysis parameters were proposed, but they were really embryonal in terms of research in 2015. But what's after? Because actually this technique was considered, and is still considered in some place in the world, something not for humans, because it's considered too difficult, too complicated, and it's not. Because actually it was a total revolution in congenital heart disease MRI acquisition. And I will explain to you why actually our routine and even clinical routine improved enormously with this kind of technique, and why and what we can study with this technique, and also what we are expecting for in the future. This is a real short technique to acquire. So this has a huge impact on your patients, because the patient tolerance, the clinic feasibility, no need for general anesthesia, a big impact on waiting list and cost, because it's a really short MRI. And a part of all this practical aspect, with this sequence, you can have the access to some hemodynamic, non-invasive information that you did not get with no other technique, invasive or non-invasive, because you can evaluate the global flow in all vessels that you want in the thorax with simple and complex parameters, study the pressure gradients in a non-invasive way, and made an anatomic 4D evaluation in a cine mode, so in movement. So the major goal of this technique is to avoid the radiation exposure. So actually we abandoned a lot of CT scan indication, the scintigraphy to study perfusion, and we avoid actually invasive procedures in the majority of cases. And a part of all that this information, we get hemodynamic data that we absolutely were not able to have before. And we are now understanding much more about the pathophysiology of congenital heart disease, as Arno will explain to you in the Fontan circulation. So how do we apply this sequence in congenital heart disease? Actually, we can calculate the flow in all places in the heart, intracardiacally and extracardiac vessel. We can study anatomy, of course, I will show some images. We can evaluate the pulmonary perfusion without scintigraphy. We can evaluate hemodynamically in a non-invasive way, complex anatomy, pre and post-operative. We can measure the pressure gradient in a non-invasive way, as inquartation, and we measure the QPQS in a non-invasive way, and then we have access to amazing complex parameters that now, actually, with these parameters, we are understanding a lot about pathophysiology. Some example, shunt, interarterial septal defect. Previously, we made a cut to understand the amount of the shunt. Now we calculate with 4D flow in a really simple way. In all communication of shunt, interarterial, interventricular, and, for example, in pulmonary venous return. Then, for example, in one of the most studied pathology, congenital pathology by CMR, the tracheophallot, we have a comprehensive visualization of the entire pulmonary vasculature and anatomy in the thorax. And we can study whatever we want. In this case, we found an associated anomaly of pulmonary vein, for example, in this patient, already operated and studied with other technique. And we can measure exactly, actually, where the stenosis is, when the regurgitation is, measuring the regurgitation fraction, the peak velocity, localize the stenosis. Of course, you should validate this technique in your center in comparison with 2D phase contrast. It was the previous sequence used to calculate flow. Every center should do it. We did it a lot of years ago, and now we actually we validate the majority of pathology, especially in Fontan, as Arno will show you, and so we use routinely without 2D phase contrast. You can evaluate anatomy in this complex patient because you visualize the flow. You are not only going to measure it, but you visualize your problem and exactly the aspects that you want to study. In simple pathology, this is a 3D volume, so you can actually move your volume whether in all plane that you want. And even in complex anatomy with stent, this stent, for example, is a major limitation of the majority of non-invasive technique. And you can study the right ventricular outflow tract, even in complex stent positioning and in complex pulmonary branch anatomy and stenosis. And you can calculate the pulmonary perfusion. In this patient, for example, was a really asymmetry of pulmonary perfusion. And even after stenting, you visualize the pulmonary perfusion. And we understood, thanks to this technique, that unbalanced pulmonary perfusion is a risk factor of right ventricular dilation independently of a pulmonary regurgitation. And you can also, in the tracheophallot, visualize coronary arteries before your hemodynamic procedure. Another pathology, for example, aortic coarctation, you can visualize amazingly actually the anatomy and the stenosis, measuring the non-invasively the pressure gradient, and study the collateral flow and exactly the place where surgeon or percutaneous expert had to intervene. And this is a case of requartation actually measured by 4D flow and then operated with the positioning of stent. And these are amazing study about non-invasive pressure gradient estimation. This is a complex case of a gland patient with VT shunt, and you can actually visualize with the same actually velocity mapping exactly the flow in all the vessels. And in complex Fontan, as Arno will show in an amazing way, we can actually perform a comprehensive study on the entire hemodynamic that is really complex in this kind of patient, and study the pulmonary perfusion in detail, and study collaterals that are really important in our patient, and we demonstrate the bad impact of this kind of collaterals only possible with this technique and with no other technique that you can study in this patient as collateral fistula and venous and intravenous collateral. even more complex pathophysiologically anatomy correction or palliation as one ventricle and half repair. There's a really complex anatomy to be studied. And we were we had a lot of difficulties to study it with the previous technique. And now we can measure all the flow, understanding what's going on in the heart of this baby, and comprehend in the really deep way actually how our surgical palliation is working. And also in all complex valvular disease as Epstein anomaly, we can really study the dynamic of the valve and measuring flow. And last but not least, the position of great arteries in follow-up, studying the pulmonary branches, and especially in complex case, and also study coronary ostia and perfusion of coronary arteries in this patient. And just to give you an example on how we can transform all this kind of information that we have in some more important concept, try to understand the pathophysiology of some actually problem of our patient. We started from the aortic dilation after transposition, normally associated to curvature, but we don't know exactly why some patients dilate aorta. And in FortiFlow, actually, we applied this kind of complex study with the Fontan model developed by the Julio Sotelo in Santiago de Chile. We found, actually, starting with FortiFlow, we understood what's going on in all the region of aorta, because we could have a comprehensive access to all these complex parameters in the vessel. And we understood which kind of parameters with which we can predict actually aortic dilation in this patient. So we understood for the first time what really was going on in this patient. And for this reason, 1 year ago, actually, we decided to work all together with the entire community of FortiFlow experts in the world, try to be more inclusive as possible. But we really wanted to write this kind of progress and advanced that we got with this technique to help community actually to use this technique that is not complex at all in routine life. Of course, then for research, you need some really expert and multidisciplinary team with engineer. But in any case, we think that it's really worth that every center that have activity in congenital heart disease should have access to this technology. And so we published this FortiFlow consensus statement in the Journal of Cardiovascular Magnetic Resonance. I really invite you to read it. And we focused especially to recommend acquisition parameters, so really to help actually community in acquisition of images. In clinical post-processing workflow, we try really to explain how post-process images, try to get also some advice in quality assurance and validation, because of course you need to validate this technique in your hospital. Then we try also to suggest how to integrate this technique into clinical practice and recommend some standards for publication of your results. Then we published also an appendix with really more detailed information in all this kind of topic. It's really easy to read, I think. Just an example of some tables that we published with all parameters that you have to settle. And what I really like to stress is then when you set your sequence and the first time or in the first period of your experience, then you don't have to manipulate a lot. So the big work about acquisition is just in the first time of your activity. And then you don't have to manipulate in your patient as you should do for other sequences, such as mapping or CNE or whatever in CMR. This sequence, once you have really have a good settle with your engineer, it's really stable. And parameters, they don't change a lot between patient in pediatric age. So it's really simple also for your technician to acquire it. And it's really feasible in clinical life. And so we try also to make you understand how to post-process the sequence that of course need a learning curve to do it. But now technology is really advanced to have stable and reproducible results. So we really want to support the diffusion of this kind of technique. And then we also suggest some publication standards that is really important to make the information that you provide to the community stable. We also publish it. It is really useful, I think, so I really invite you to read if you are interested into a sort of guide also in the CMR website is how do I do 4D flow MRI? And we try to develop the major chapters. So how to acquire these are all the chapters that we publish in this PowerPoint. So it's really simple to read, and we try to be really exhaustive. So it's 4D flow MRI sequences. So how to acquire them, with all parameters that you should choose. But I really repeat that all this kind of sector is just at the beginning of your activity. Then your sequence is done and you can use, and your technician will don't have much problem. Then we try to suggest the protocols for specific pathology. We try to also suggest how to post-process and how to analyze advanced thermodynamic parameters, how to visualize them and measure them, because it's really important that we measure a lot of parameters, for example, intracardiac flow. And we really try to be synthetic in this kind of PowerPoint slides. Then we show some clinical application, especially in valvular heart disease, aortic disease, heart failure, so also in adult fields actually, and especially in congenital heart disease. And then we try also to trace some future direction. So I'd like to conclude that 4D flow is a really fast and robust technique for clinical non-invasive evaluation in congenital heart disease, especially for hemodynamic question. It allows complete anatomical and functional analysis in complex anatomies, avoiding radiation and invasive procedure. It provides insight in new physiopathological aspects. So it's helping us to understand actually pathologies and to understand how to treat them and how to tailor actually our action on the patient in terms of surgical intervention, in terms of medical intervention. And so I think that this technique is really helping in progress in knowledge in congenital heart disease, and better hemodynamic understanding will lead absolutely to tailored patient treatment and better follow-up. Thank you very much.
Thank you so much, Francesca, for your beautiful overview. Any questions from the audience? Otherwise, I will proceed to my presentation. Yes. Let's go on to my... Okay, can anybody see my screen? Give a shout out.
Yes, perfect.
Yeah, in presentation mode as well.
Yeah, this is, I think this is okay. Yeah.
Okay. Well, again, also from my point, thanks for inviting us to have this webinar in the ERN reference network, GUARD-Heart, congenital heart disease. And especially, I think the 4D flow is especially useful for the congenital heart disease. Francesca gave a beautiful overview on the applications in multiple congenital heart disease. And I want to dive a bit in more detail into one of the patient categories where it really helped us from our research line to figure out what's going on in a special population of patients. And it is the single ventricle patients. You may know that congenital heart disease are the most prevalent congenital defect that exists, and especially the single ventricle patients, they represent the most severe end of the spectrum with only one functional ventricle. And in the 1970s, Professor Fontan launched an idea in the creation of the Fontan circulation that can really help these patients grow into adults, but at the expense of some complications. I've put two echo images in my presentation. That will be the only echo images I will show you, but it's very nice to see this is a patient with a tricuspid atresia, where you can see over here the left ventricle functioning quite well, and this is a case of a well-functioning right ventricle in a patient with a hypoplastic left heart syndrome. And as you can see in these cases, the right ventricle, the left ventricle cannot be used to sustain the systemic or the pulmonary circulation. And how we do it nowadays was very nicely depicted in a review in Circulation a couple of years ago on the management of patients with single ventricles and Fontan circulation. And in general, we do a two-step approach or three-step approach, but the completion of the Fontan circulation is done in two steps. First, creating of a Glenn anastomosis, so by connecting the superior caval vein to the pulmonary artery. And the second step that we normally do at the age of 2 to 4 years of age is connecting the inferior caval vein to the pulmonary circulation, either by placing a rigid Gore-Tex conduit or by creating a intra-atrial tunnel from the IVC to the pulmonary artery. But as we experience nowadays, there are a lot of morbidity and increased mortality in this patient. They experience decreased exercise capacity, but also liver fibrosis, protein-eluting anthropathy, even renal problems. So there's a lot going on in these patients at long-term follow-up. And based on that statement published 4 years ago on the management of Fontan patients, there were a couple of gaps in our knowledge identified, and they were especially focusing on how do we evaluate the Fontan circulation? Do we understand fully the Fontan physiology? And do we understand the mechanisms of end organ damage? And also there's an individual variation in these patients, as you can show. I will show you in a couple of slides. And I'm really sure that 4D flow can be used to at least bridge part of these gaps, as you have beautiful evaluation of the flow patterns, but also advanced parameters. And as Francesca showed you, you can get a total volume of the Fontan circulation, but also from the intracardiac perspective. This is the case of a double-ended left ventricle, where the blood to the aorta is going from the left ventricle through a VSD, ventricle septal defect, toward the right ventricle towards the aorta. And you can see the areas of energy loss over there within the heart. In this presentation, I will focus especially on the Fontan circulation, but also for the intracardiac evaluation, valve regurgitation, diastolic function in the single ventricle patient. 4D flow can really nicely be applied. So what are the recommendations on CMR in general in these patients? It is recommended to do a CMR examination every 2 to 3 years during follow-up. And when you look at how to evaluate hemodynamically the Fontan circulation, most of the times you do phase contrast, 2D phase contrast images of all the major vessels, the aorta, but also the pulmonary arteries, superior caval vein and the inferior caval vein. And here I can show you some examples what 4D flow can really add to the evaluation of the Fontan circulation. This is a case where you can clearly see there's a huge helical flow within the center of the Fontan circulation. This is a case where you can see a vertical flow at the proximal part of the left pulmonary artery. This is the patient where you can see the acceleration of blood from the inferior caval vein to the conduit, or a distorted connection between the inferior vein towards the conduit, and also where you can see the Glenn anastomosis. You can see really abnormal flow patterns within the Fontan circulation. A couple of years ago, Israel Valverde, who is now in Toronto, already showed that you can nicely use 4D flow instead of 2D flow to have a very nice volume of the Fontan circulation with high correlation, with low differences in the Brent-Elman evaluation. So it can be used to evaluate the 2D scans, replace the 2D scans to collect all the measurements that you need also for the calculation of collateral flow. And what we used it for is to really look at the conduit size. As was shown in the publication of 2019, we do not know exactly what is going on, especially to understand Fontan failure and what is going on within the rigid Gore-Tex Fontans in our patients. So this is a case example of a patient that got her extracardiac conduit with a diameter of 60 millimeters at the age of 3, which is a body surface area of 0.6. And we did a MR scan 70 years later with a body surface area of 1.8. You can nicely see that there is dilatation of the inferior caval vein, of the liver veins, going into the rigid conduit that is, well, looks quite smallish. And When you look at the velocity patterns over there, you can see an acceleration from the inferior caval veins, hepatic veins, towards the conduit, extending into the left pulmonary artery. And what is very nice of 4D flow, you can really look for where is the velocity, where is the blood coming from. And in red in this patient, you can see the flow that is coming from the conduit with the accelerated velocity, accelerated blood velocity, ending up quite high within the Glenn shunt. So it is really impactful to have a acceleration of blood over there, protruding into the left pulmonary artery, but also getting high up into the Glenn circulation, causing very abnormal flow patterns over there. But as Francesca already nicely showed, there are more advanced parameters that you can look for. In this case, on the left, you can see the increased wall shear stress over there. And we know that endothelium is very active when it has oscillating wall shear stress differences, maybe be prothrombotic. And these maps really provide additional information on the places where we can see abnormal wall shear stress, but also the areas of increased energy loss, as in this case can be seen within the conduit. And as we strive for the most efficient Fontan circulation, because it's a passive flow towards the pulmonary arteries, there's no contracting ventricle to protrude the blood towards the pulmonary artery. You have to go for the Fontan circulation that has no energy loss, or the lowest energy loss achievable. And as you can clearly see, these images really, well, making us doubting whether the 60 millimeter in this case was the right decision. So when we look for the conduit size, we did a lot of real-time flow, but also 4D flow in these patients. As you can see, our approach used to be to use 60 millimeters, but nowadays we used 80, especially 20 millimeters conduit. And you can see there is an area change from the inferior caval vein towards the conduit of 10%. So it has some meaning. It has some. It is causing some problems, and as you already showed you can see the increase in flow velocity. So based on the volume that you are creating, and also that you know all the velocity within that geometry, you can really nicely segment due to the center line method that has been developed by Joe Juffermans to look at all the different spots within the Fontan circulation. And as you can clearly see, that especially the smaller the conduit, the circumferential area normalized for body surface area, the lower that is, the higher the energy loss is. And also the left pulmonary artery is causing a lot of problems, or is one of the main driving forces for energy loss in these patients. So all the different areas of the Fontan circulation can show abnormal flow velocity. This is an example of where we studied the connection between the inferior caval vein towards the conduit. And as you can see on the left, it's quite nice, straightforward connection. But the two examples on the right are patients with a really disturbed connection between the inferior caval vein towards the conduit with increased energy loss over there. And you can imagine that is not contributing to an efficient Fontan circulation. So we studied the whole group of 60 Fontan patients, but also did some liver imaging. So the corrected T1 is saying something about the fibrosis or congestion of the liver, and we could correlate the efficiency of the Fontan circulation with the corrected T1 mapping of the liver. And as you can nicely see over here, that the higher the energy loss within the Fontan circulation, the lower the exercise capacity, but also the higher this corrected T1 mapping, suggesting more fibrosis or congestion with a more adverse hemodynamic of the Fontan circulation. And again, when you do a segmental analysis, you can see that the conduit and the LPA are the segments that contribute most to that. Our recent study was accepted in JAHA last week, and in this study we used the same cohort of patients but related multiple metrics of adverse hemodynamics to estimated glomerular filtration rate. And we can see nicely that within the different metrics of adverse hemodynamics, it is correlated also to renal abnormalities. So it has a profound effect on liver health, on renal health, when you have a adverse conduit, a failing Fontan. And these are quite asymptomatic patients. So it was really, from my point of view, alarming, the things that you see within those quite small conduits. So Professor Dudechem was earlier on questioning what is the best approach towards for the single ventricle patient towards the optimal Fontan, and he published this editorial a couple of years ago. And I'm not sure yet what the best way to do, because we had especially done some imaging in the extracardiac conduit, but also had a couple of patients with dilatation of the lateral tunnel. So I think the future research should focus on the differences between these two patient groups and provide the answer to this question. What we do know is that with the use of computational fluid dynamics, which is published last month, is that you can see when you have a bigger conduit and you can virtually enlarge it from 16 to 22 millimeters, you can see that there's a 50 to 60% in reduction of energy loss. So when you have a larger conduit, when you reach adolescence, that's really more beneficial. So in conclusion, I think 4D flow is really good for the pathophysiological mechanisms in Fontan failure. It provides unique insights, reveals important abnormalities, and can already, as Francesco already showed us, have clinical impact and can be used in clinical practice on a very fast way and accurate way. And I think we need more 4D flow research for serial follow-up. Also use computational fluid dynamics, and really have to dive into what's the best treatment strategy is for those single ventricle patients, because we already can be sure that the smaller the conduit, the bigger the liver problems, the bigger the renal problems, and really, well, have to do something about that and think about better and treatment strategies for these patients. Of course, it's not work that I've done by myself. There's a whole lot of people, especially Jos Westenberg from the radiology department. He did a lot of research in 4D flow in our department. I'm really thankful for him being part of this research team, and all others you can see here are part of this this research. Thanks for your attention. Any questions from the audience? Okay. Then I think we move on to Professor Dudechem.
Perfect. Let me know if you.
Yes, we can see your presentation.
It's the main screen now. Okay.
Yeah, it's the main screen now. Perfect.
So my name is Yves Dudechem. I'm a cardiac surgeon. Let me see swap display so I'm facing you. Like that's okay. Yeah. Okay. So I'm a pediatric cardiac surgeon. I work in the Children's National Hospital in Washington, D.C. And I did some work 25 years ago with Dr. Rust, and we started collaborating at the time. So my real area of expertise is the Fontan procedure. Arnaud has explained to you, when you have a single ventricle conditions, you make a pathway that bypass the right heart, and you can do it in various ways. The initial way was to isolate the atrium from the rest of the heart and connecting the atrial appendage to the pulmonary artery, but you can imagine that the blood from the SVC had to swirl around the atrium before getting there. And so my mentor, Marc Delaval, designed this more streamlined operation, the lateral tunnel, which allowed the blood to go from the SVC to the right PA mainly, and the IVC to the LPA. And the natural evolution for everybody was the extracardiac conduit. And to tell you an idea, I have the data from North America, and I know that the rest of the world is equivalent. 85% of the extracardiac conduit, or the Fontan done today, is extracardiac conduit, and about 15% lateral tunnel. The people have abandoned the atriopulmonary connection, because we saw that with the swirling of the blood inside the atrium with time, this atrium start dilating, which will giving arrhythmia, thromboembolism, and even compression of the pulmonary veins. And so that's the distribution that I explained to you. And so I can summarize my own background by saying I'm Mr. Fontan. If you type my name on PubMed, I have 152 paper on Fontan, yesterday, and keep going. I have some biases for a long time against computational fluid dynamics, and I put 4D MRI in the same bag at the time. That's an old paper from the team of Michigan. And so the team of Michigan was doing really well. They had a special shaped Fontan where they put the PA at the back of a dilated area that they patched. And everybody knew they were doing well, so they do the computation fluid dynamic and say, "Oh, it's very optimal for the flow." And I thought, what if they had found negative results and it was not optimal? They would have changed. No way they would have changed anything. How much this type of surgery helped in our practice? Another paper that influenced my negative bias is that a paper where they put a diverter of the flow in the lower IVC at the anastomosis, so that the flow goes ideally on both sides. And when you read the detail of the paper, if you move this diverter 1 or 2 millimeter, it changes completely the flow, and you can have adverse flow patterns. And that's not realistic. There's been a lot of studies that say, "Oh, you should do it this way or that way," but it's not in a way that can influence the way I can do my surgery. And as Arnaud mentioned, I started to have some doubt about the extracardiac conduit, though, because I did some liver study, and I saw undoubtedly that in these liver studies, the extracardiac conduit patient had more liver fibrosis. And I've been doing extracardiac conduit for my whole life, and I was convinced it was the best operation. And then I came to Washington, D.C., and they had put a lot of 14 and 16 millimeter conduit. So I started to see these images of narrow conduit with dilated IVC, and a few of them had quite an impressive level of liver fibrosis. And so that's a teaser from a paper that is going to be presented at the ATS. If you look at the extracardiac conduit in red here, 25% of them had liver cirrhosis by the age of by 15 years after the Fontan, against 2.5% in the patients with the lateral tunnel. And so that changed my mind. And then I got to the privilege of being in the jury supervising the thesis of a PhD student of Mark Azekam and Arnaud Roest, showing that actually all the images that Arnaud presented to you and the abnormal hemodynamics that were there, the impact on the liver, and I think that what was important is that instead of making a supputation of what would happen if you have this and that and you change the change, and they change the shape or the size, is that they collected correlation between real life events, between the exercise capacity and what they were seeing. And then practical stuff, like I love this little paper where they see that the stump of the main pulmonary arteries, you leave the stump of the main pulmonary artery on the circuit here, instead of cutting it and shaping it so that it's a good cylinder, you create this adverse flow that impact the outcomes. And that's something that I've been saying for my whole life. So if I got somebody that give me a proof of what I was saying was right for a long time, I get convinced. And so to the final paper that showing that, you know, the ideal size of the conduit should be between 22 and 28 millimeter. And for me, the proof is that that is right, is that the lateral tunnel naturally take that shape. And so I'll present you a few works from Tom Loke, who's a cardiac MRI guy here in Washington, DC, and how these patients with small conduits can be seen to have adverse flow that affects the liver. And these are the examination that we start to look at every patient discussion now. So the flow is not limited to the conduit, and Tom is looking a lot about the adverse impact on the circulation of atrioventricular valve regurgitation. And there are other examples. So to go back to the Fontan, the conclusion of that is I personally, in the last year and a half since I've seen these, changed my practice. So I've changed from the extracardiac conduit back to the lateral tunnel, which was the operation that I've never done before, but I've seen Marc Delaval, who invented the operation, do that. And my mentor in Belgium, Jean Rubet, was doing the same operation. And I convinced my cardiologist as well. And we all convinced that when we have a small conduit, we should upsize them. So I've done 6 upsizing in the last year and a half, which is going to be published actually soon. There are other fields where 4D MRI can help us. And I give an example, tetralogy of Fallot. Tetralogy of Fallot, they have a leaky pulmonary valve after the operation, and the right ventricle increase in size. And we always try to look at what size. Is it too late to put a valve in to reoperate this patient? And that has been a big issue. And I'm always inspired by this work from Leiden at the time, that dates from quite a few years ago now, where they could look at any size before and after. There's no cutoff at which you do not recover the right ventricular volumes. So the solution is likely somewhere else. And again, Tom Loke is trying to identify the flow topology. And when we say flow topology, is trying to classify this right ventricle into different types of shapes to see if it's not only a question of volume of the right ventricle, but the way it contracts, which part contracts before the other. What is an ideal shape that still give you a function, because there are elements beyond just the mere volume. Another example, again on single ventricle, we know that when you have aortic atresia, you result with this really tiny, on the top here, left ventricle, which makes a ball of muscle inside the right ventricle. And so you're losing the septum. I've tried to make some studies, and that's one of them here, where I'm trying to identify what are the morphological factors, what explains why aortic atresia, having aortic atresia, is a risk factor for any single ventricle condition, early and late. And we haven't found that. And I think that 4D MRI is something that may enlighten us by having a view of how the blood circulates in the heart of this patient. I hope you can see that. That's a patient that is supposed to have a normal aortic arch. I mean, you see the ascending aorta, you see the descending aorta, you see the transverse arch. I know that this arch is abnormal, but there was 10 millimeter gradient on the cath. But I know that there's restriction. That patient had a single ventricle and way too much pulmonary blood flow for the banding that this patient had. And so all the patients want to transfer this patient to a transplantation. And by relieving this aortic arch obstruction, I managed to get the patient back on a track of a single ventricle palliation, which a much better life expectancy. And I find myself caught numerous times where the aortic arch is obstructed, but the numbers given by the cath does not give me an obstruction. And I think we've been focusing on a gradient, but in single ventricle situation, the flow can be affected in a way that the gradient are not extraordinarily high. And I've made a paper saying that we should do cosmetic surgery on these arches. Again, 4D MRI helped me in this matter. So in conclusion, I think it's no longer a matter of knowing whether 4D MRI can help to change the future. I contend that the 4D MRI has already changed practice today. Today, I have changed, because of these studies, I have changed from the extracardiac conduit to the lateral tunnel. And honestly, in all modesty, I have one of the biggest voice when it comes to Fontan surgery in the world. So if I say to everybody that I change to lateral tunnel, my bet is that this 85% extracardiac conduit will decrease very rapidly in the next few years. And I think it's only at the beginning of what 4D MRI can give us to the field. Thank you very much.
Well, thank you, Professor Dudecam, for your presentation, and thank you to Dr. Roest and Francesca Raimondi. If there are any questions, we can add a couple of minutes. I didn't see any questions in the chat, but maybe there is
one question, please. If you, you hear me?
Yes, Philippe. Yes, please.
Yes, thank you, Philippe Chevalier. St. France, Lyon. It's wonderful work. We use it in some cardiomyopathies in Lyon, but it's just the beginning. So we are trying to quantify the flow inside the left atria. But I was wondering about you observe any differences between 3 Tesla on 1.5 Tesla in terms of MRI resolution?
Yeah, I can answer. Actually, the 40 normally the 3 Tesla is more performant for 4D flow. It's preferable because it's a higher signal to noise ratio, so it's better normally. I don't know which kind of machine do you have, but normally in terms of visualization and also calculation, 3 Tesla is better for every machine.
Agree.
But the signal to noise ratio is much higher with 3 Tesla. This is not must be perhaps a trap. No, it's really a big asset to get it in the 3 Tesla. We have both 1.5 and 3 Tesla, but on the term, what device are you using? We are using Philips, but I know there is also Siemens. So do you have any preference about the machine?
It's a complicated question. No, I mean, actually the 4D flow sequences in terms of commercial ones, because you have to know also that a lot of research is done by homemade sequence. So we are not using the same sequences. For this reason, also we appointed this in the consensus statement, saying that when you publish, you have to be really clear in which technology you are using it. And there are big differences between sequences. And speaking about only commercial ones, there are difference between the 3 biggest ones, so GE, Philips, and Siemens. And also it depends on the contrast product that you use. If you use contrast, but you are in France, so you had the same problem as me, that in Europe actually we don't have ferromoxitol. It's one of the most used contrast products in the United States, and there is one sequence that it's one of the most performant in 4D flow is from GE. It's a music sequence, but music sequence works only with ferromoxitol. So it's not used in Europe because we can't use it in Europe. So, you know, there are some differences between machine and also chronologically speaking, advances in 4D flow were different from GE, Philips, and Siemens because the first one in Europe that had approval for clinical use was General Electric's in 2015, more or less. And then the other follow it in terms of clinical approval, official one. And so then it depends on what use you do, because if you use in adults, it's different than in children in terms of resolution and specific sequence characteristics.
But it's also very time consuming, no? Perhaps it takes time, no, for the procedure, for the acquisition process. Some patients are complaining.
The sequence, you mean the acquisition sequence?
Yeah.
It's less than 10 minutes. It's 7, 8
minutes. So okay, I don't know. Here we have 1 hour. So
no, it's not. Normally, it's 7, 8 minutes for the entire thorax.
Yeah, and it also depends a bit on the post-processing software, of course, you use. And my colleague Jos Westenberg published a paper where they did post-processing on valve tracking between 3 vendors and 2 1.5 and 3.5 Tesla. And in the post-processing setting, it was a high consistency also between the vendors and between it was in adults, but so when you look at the post-processing, it doesn't matter that much. Of course, you want, especially in pediatrics, the best spatial resolution. But in general, I think all the vendors now can get nice images and nice 4D flow clinical sequences.
One last question is about the contouring, you know, with the manual, you manual or automatic contouring? The contour of the cavities of the walls?
In congenital, actually, it's manual. You can do automatic stuff, but, you know, it's manual.
Oh, it's not reliable, you mean, when it is automatic. Okay. Yeah. And how long does it take for you to reproduce?
It depends a lot about the pathology. It depends also on your learning curve, because when you speak about Fontan, actually the analysis, the clinical one, I mean, of course, not the research one, but the clinical CMR for a classic Fontan patient require a comprehensive measurement also for consistency of your data and mass conservation. So in all actually vessels, so you should have also to evaluate collaterals, you should have in flow in every vessel. So you have to have aorta, pulmonary arteries, pulmonary veins, gland, Fontan, and everything. So can takes also 1 hour or 1 hour and a half if you are an expert.
Yeah. Okay. Thank you very much. Very nice work. Thank you. Very encouraging.
Thank you, Philippe. Is there anyone else who, for a final question? I don't think so. Well, this webinar was recorded, so we will put it on a website, on the ERN website, where it is available for review soon. So thanks again, and thanks also to the participants, and looking forward to meet you next month, but not before. I wish you a very Merry Christmas, of course.
Yes.
So have a nice day.
Thank you so much. Bye
Thank
all.
you. Okay. Bye.
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 Bye-bye.